Today I'm here to talk about a different project that was commissioned by the Health and Care Research Wales Evidence Centre. And we looked at evaluating health and care pathways in the last year of life from non-sudden causes. So before I go into the detail, I would like to thank all of my co-authors who have provided input on this project, and of course to all data providers who make anonymised data available for research, which enabled this research to take place. So as Chris mentioned, I'm Rhiannon Owen, I'm Professor of Statistics and I'm based at Swansea University. Okay, so just to give you a bit of a background as to what the problem is that we're trying to address. So as we know, more and more people are living with multiple long-term conditions. And this means that there is increased demand on our health and care services in the NHS and more broadly. And in particular, there's an increased demand on end-of-life and palliative care services. But at the moment, little is known about how individuals interact with health and care services at a system level. And by that, we mean across hospital and care settings for those in particular nearing the end of their life. What we do know and what previous studies have looked at is evaluating healthcare utilisation, particularly in specific populations. So for example, end-of-life cancer patients, for example, or they've looked at specific settings. So they might have looked at how individuals interact with hospital settings, for example, or perhaps hospice care, and so on. Some studies have tried to summarise sort of places of care towards the end of life using things like summary statistics, so proportion of people in each healthcare setting at any point in time. And there have been many studies that have looked at the cost implications of palliative care and end-of-life services. And as we know, these sort of end-of-life services can be very costly from a public expenditure point of view. So why is this research important? Well, one of the things we want to do is to understand these pathways of health and care service utilisation to inform Welsh Government policy for palliative care and end-of-life services. So as part of this project, we worked with the National Programme for End-of-Life and Palliative Care in Wales to help identify the sort of key questions that needed answering to inform their policy needs. So the overall aim of this project was to assess how individuals interact with these health and care services in their last year of life before death from non-sudden causes. And these non-sudden causes were defined as all deaths with the exclusion of external morbidity and mortality and traumas. So these are typically chapters 19 and 20 in the ICD-10 code list. And our key objective was to examine the rate of health and care service utilisation, particularly by palliative care registration, but also by demographic characteristics. And you can see this pathway that individuals could take on the right-hand side of these slides. So each of these states represents different health and care service utilisations. And you can see that individuals could transition to and from these states with the exclusion of death, where when people move into the death state, they obviously remain in that death state. But for all other pathways, they could go to and from emergency admission and their own homes, for example, or care homes and so on. So one of the things that was important to us was to try to account for and model these competing pathways. So for instance, somebody who's in their own home may attend an emergency admission for their healthcare needs, and this pathway would be competing with potentially admission to a care home with nursing facilities, for example. So we wanted to make sure that we could account for those competing pathways, and I'll talk a little bit more about that later on. So of course, the data that we used the SaIL data bank, and we specifically looked at linking their demographic and mortality data using the Welsh Demographic Service dataset, where we were able to get information on their anonymised residential information using the residential anonymised linkage fields. And we link this to their annual district death extract data sets to get their information on their causes of death and time of death, so the ADDE data set. And this demographic and mortality data was then linked to their health records, and in particular linked to the Welsh longitudinal general practice at the individual level, the emergency department dataset, and the patient episode database for Wales, so that we could capture all admissions to a secondary care setting. And we further then linked this to the care home dataset, which via these residential anonymised linkage fields, we could understand when an individual was admitted into care homes, how long they stayed, and also the type of care home that they resided in, whether that be a nursing care home or a care home without nursing. So as I mentioned, we included all those who died of non-sudden causes between the 1st of January 2015 to the 31st of December 2023. And we had a look back period of 1 year of their health and care service utilisation. So the total coverage period was from 2014 up to 2023. And we included all those with at least one known Welsh residency in the last year of life. So the reason that we did this was so that we could capture those in long-term, usually healthcare settings that may not have a Welsh residency at cohort start. Because for people who are in a care home and then get admitted into hospital, if they're there for a long period of time, they might lose their care home residency, and that process is restarted when they are discharged. So we wanted to capture all patients, and this is why we looked at Welsh residency in the last year of life, just any one. But what we did do was make sure that we included all individuals where we had complete follow-up, so we knew where they were at all points in time, meaning that we excluded anybody that did migrate outside of Wales within this time. So once we did this and linked it at the individual level, we had 267,199 individuals. And they had complete data for inclusion in the analysis. In terms of palliative care registration, we got this information from the Welsh longitudinal general practice dataset, where we looked to identify Read version 2 codes that were recorded within their GP records. And these are the read codes that we used, but these read codes are recommended by the Quality Outcomes Framework, or the QOF, and the gold standard framework for identifying those who would be effectively put onto a palliative care register as part of the Quality Outcomes Framework. And as I mentioned earlier, we wanted to estimate all of these competing possible pathways of health and care service utilisation and death and individuals' own homes. And to do this, we used a multi-state modelling approach. And this effectively allows us to simultaneously estimate all of these different competing pathways. And it does this by estimating all of the possible transitions that could have been made to each of these health states at any point in time. We used Cox proportional hazards regression models to assess the effect of palliative care registration, and these were adjusted for age, sex, area level deprivation, and rurality, in addition to fitting palliative care as our key exposure. The similarity between transitions within individuals were accounted for using robust standard errors, and we presented our results using adjusted hazard ratios to compare the rate of these transitions by palliative care registration. As a secondary outcome measure, we looked at expected length of stay, and this is restricted to 1 year, so the complete follow-up that we had for each individual. And we use this as a sort of proxy measure of healthcare utilisation or healthcare use. And as you can see on the right-hand side, this is the schematic of our multi-state model. And the arrows are indicating the direction of effect that, or direction of transition that these individuals could move to and from. Okay, so in terms of our findings, as I mentioned, we included 267,199 individuals in the analysis. Their median age was 81, approximately half were female, and just under 27% of these individuals lived alone at cohort start. And this perhaps reflects the complexity of end of life care for these people. Of those included in the analysis, 28% were registered for palliative care throughout the last year of their life. And underrepresented groups on the palliative care register included men, those of Asian ethnic groups, most deprived communities, and those individuals living alone. In terms of the palliative care register, the primary causes of death were mostly cancers. So 50% of palliative care registered individuals died from cancer as their primary cause. 12% were cardiovascular disease, 10% were related to dementias, and 10% were respiratory diseases. On the right-hand side of your slide here, you can see the health and care settings for each of the years of follow-up. And along the y-axis, we have our percentage of total person days, so the proportion of days spent in each of these healthcare settings. Along the x-axis, we have each of the years of follow-up. And you can see that overall, the sort of patterns, the trends were consistent across these years from 2015 up until 2023. In terms of the comparison between those who were palliative care registered and those who were not, you can see how people spent their time by the shaded regions in these plots in the last year of life. So along the x-axis, we have 1 year prior to death, right the way up to their date of death. And along the y-axis, we have the proportion of people who are spending time in each of these settings. And as you can see, on the left-hand side, we've got our patients who were not registered for palliative care, and on the right-hand side, we've got our palliative care registered. As you can see from these plots, the majority of time in their last year of life was spent in the individual's own home. And there was an expected length of stay of 304 days for the palliative care registered individuals on the right-hand side, compared to 320 days for those who were not registered for palliative care on the left-hand side. And this is perhaps reflected in the block of red in each of these plots here. But what's most important about this finding is that there was clearly an increased use of urgent care services, which is illustrated by the lighter blue shaded region here, particularly for those who are not registered for palliative care services. And you can see this by this sharp increase in this blue proportion as individuals move closer to death. And this was sort of seen less in the palliative care registered individuals. What we did find is that there were lots of multiple urgent admissions for those who are nearing the end of life, which would perhaps indicate sort of lower value care. So the closer individuals got to their death, the more transitions they were making, very, very close up to their time of death. But also these multiple urgent admissions to and from different health and care settings and their own homes, which might reflect sort of lower value care. Whereas for the palliative care registered individuals, you can see that this is a more kind of steady incline where there was more services being provided within residential homes, in particular care homes with and without nursing. And that didn't seem to change so much as we got closer to individuals' own deaths. But thinking about the pathway, as you can imagine, the health and care pathway is incredibly complex. And we've tried to illustrate what this looks like on the right-hand side of this plot here. So in total, and what this plot is showing you is that 1.85 million transitions were made during the last year of life for all individuals. And the plot illustrates how these individuals move from different settings. So if you look at the red line here, these are individuals who are residing in their own home. And if you look at the darker blue shaded region here, this is the proportion of individuals who transition to an elective admission. These purple caterpillar type loops are showing backward transitions. So these were individuals who then returned from their elective admission back to their own home. And you can see that also for a large proportion of emergency admissions returning back home. But what this plot shows you is that the majority of emergency admissions, this lighter blue region here, were actually made from individuals' own homes, where 90% of emergency admissions were from people's own homes, meaning that less than 10% of emergency admissions were made from care homes with and without nursing combined. But of those who did transition to an emergency admission, 71% of care home without nursing transitions were made from emergency admissions, and 56% of nursing home admissions were from emergency admissions, sort of suggesting that there were perhaps more efficient pathways of care to care homes via emergency departments. And in terms of the comparison between palliative care registered and those who are not registered, we can see that the lighter blue lines here are showing the cumulative incidence of these transitions over time, up to 1 year, so up to their death effectively. And you can see that there's a slightly steeper increase in the rate of emergency admissions, this lighter blue line, from individuals' own homes for those on the palliative care register. And this was a 23% increased transition rate compared to those who were unregistered. In terms of emergency admissions from care homes, and this plot here is showing the nursing care homes, and again this lighter blue line is showing the rate of emergency admissions. The palliative care registered individuals experience a 17% and 18% lower rate of emergency admissions from care homes with and without nursing respectively, and this was compared to the unregistered individuals, holding all other factors constant. In addition, palliative care registered individuals experience an increased rate of discharge from emergency hospital settings. So this plot here is showing you where these individuals transition to from their emergency admissions for the palliative care registered and unregistered individuals. And you can see on the right-hand side is our palliative care registered patients, and they had an increased rate of transitions to nursing care homes with and without nursing compared to those who were unregistered. But they also had an increased rate of transition back to their own homes, which resulted in a reduced length of stay in these urgent care settings for palliative care registered patients of 25 days compared to approximately 27 days for unregistered. So in summary, palliative care status had an important impact on health and care service utilisation at the end of life. And we found that the majority of time in the last year of life was spent in an individual's own home. And this was across both palliative care registered and unregistered individuals. But there was an increased demand on urgent care settings as proximity to death became closer. And this was particularly pronounced for those who were not registered for palliative care services. And these sort of multiple urgent hospitalizations in the final days of life and or transitions very, very close to death may suggest low value care for these individuals. But palliative care registered patients appeared to have a higher value care with fewer urgent transitions closer to their death. So in terms of policy recommendations, we've suggested that there's a need for targeted approaches to efficiently identify individuals requiring palliative care services, and particularly from these underrepresented groups that we've found from this research. In addition, given that the majority of time is spent within individuals' own homes, and 90% of emergency admissions came from people's own homes, we suggest that additional support provided in people's own homes, where it is appropriate to do so, can help us to alleviate these pressures faced in emergency departments. which may help us to optimize this system management. So look for opportunities where individuals might be better cared for, perhaps in care homes with nursing as opposed to emergency settings, for example. And this will hopefully improve the care for those nearing the end of life as well. So resulting in this sort of higher value care that we were seeing in the palliative care registered individuals. So if you're interested in this research, this has been a bit of a whistle-stop tour of the findings. You can find the results in more detail in this preprint in the Lancet series following the links here. I've also put a QR code to my LinkedIn where I'll keep you up to date on the progress of this research, should you be interested.